So today I will present you the theory of consciousness and how they can help us understand anesthesia. I have no conflict of interest, but first of all, what do we mean by consciousness? So we define it simply by having any experience or subjective experience that one can have. So that can be visual experience, auditory experience, but also any inner thought that you have is considered as being a conscious experience. But at the clinical level, we measure consciousness through two main components, awareness and arousal. Arousal is basically having eyes open, eyes closed, and this is mediated by mostly the brainstem, like here. And then you have the awareness, that's most commonly what we call the subjective experience, and that's mediated mostly by the cortex, and more specifically the frontal parietal network, as you can see here in orange. And then awareness can also be divided in two different components, awareness of the environment, which is linked to your external world, so now you're listening to me, or if you hear something in the room, or you see me. So this is all awareness of the environment, and that will mediate external part of your brain, as you can see here in red. And then you have awareness of the self, so that's everything that's related to yourself, your inner thought. If you're thinking about what you're gonna eat tonight, for instance, that will activate internal part of your brain, as you can see in blue. And this awareness of self and environment is switching every 20 seconds spontaneously. So knowing those two components, then we can look at all the different states of consciousness. So you and me now, even if it's after lunch, you should be conscious and aware. So you are both fully awake and fully aware. Tonight, when you go to sleep, those two components will decrease. However, when you start dreaming in REM sleep, or if you have lucid dreaming when you are waking up in your dream, then you are a bit more aware than awake. Then you have coma, no awareness, no wakefulness. Anesthesia, same, but we'll see later that it's not always the case. And then sometimes you can have a dissociation between wakefulness and awareness. And this is the case, for instance, of patients in a vegetative state, or unresponsive wakefulness syndrome, but also in specific epilepsy or somnambulism. And then after severe brain injury, you can recover some minimal sign of consciousness, so that's a minimally conscious state where you see that you're a bit more aware. So this framework is quite old, you see 2005, and then 4 years ago we have updated it with three components. Wakefulness, internal awareness, so again this inner thought process, and then connectedness, that's how you are connected to the environment. And as you can see in this more detailed graph, you have general anesthesia here. It's always low internal awareness, low wakefulness, and low connectedness. But now we know that sometimes the patient can recover consciousness during general anesthesia, and this, or some people can dream also during anesthesia. So if you use the technique, the isolated forearm technique, and you get a response, so the patients will squeeze the hand when you ask, then of course they will be connected, and so then you will have an increase of connectedness. So that's to give you a bit the framework of what we mean by consciousness. And here I will present you 4 different theories of consciousness. The first two are the most well-known in our field, and they have some empirical data that can back up them. And then the last two, they are coming into the field of consciousness research, but they have also been used in other topics. So the first one is the global neuronal workspace theory. So that has been developed by Jean-Pierre Changeux and Stanislas Dehaene in Paris, in France. And so basically what they suggest is that once you receive an incoming stimuli, so in this example from visual, so like you see me, and it will activate the back of your brain, the visual area, and then this will start to have some propagation, like feed forward. But if it's not strong enough, it will stop here, and then the information will not become conscious. And here they talk about subliminal processing. So to be conscious, this information has to be even stronger, and it has to reach other brain area, more specifically the front of the brain, the prefrontal area, but it has also to come back. So feed forward and feedback connection. And they call this ignition. So to be conscious or to become conscious, you have to have an ignition in your brain. So here, if we go more into the detail, and this is an illustration from the work of Montupil and Cardone from our group, you can see more specifically what happens in this theory of consciousness. So you have incoming sensory information that will activate local processor. If it's audition, it comes here. If it's vision, at the back of the brain. And then if the signal is intense enough, it will be propagated in the frontal and parietal area into this global workspace independent processor. And that's the ignition that they mentioned. And so to become conscious, then you have to have this global neuronal activation. As you can see it, so it comes into the spotlight through a recurrent processing of the information. And here they have shown, if you use EEG with evoked responses to auditory or visual stimuli, you see that in the front of the brain, you will see a brain response at around 200 milliseconds in the frontal area, and then at the back of the brain around 600 milliseconds, and that's the signature of the global neuronal workspace. The second well-known theory is the integrated information theory by Giulio Tonoli and colleague in the US. It's based on different axioms and postulates. I won't go into the detail. It comes from it has a mathematical approach, and it also starts from the phenomenology itself, so from the subjective experience. And there are two main components, information and integration. So for a system to be conscious, it has to have information, and this information needs to be integrated. As you can see here in the middle, if you stimulate a system, then you will have a reaction, and depending on where you look at the system, the response will be different. And that allows consciousness to appear. If you have a loss of integration on the left, you stimulate, it does activate, but it stays local. So most of the other part of the system doesn't have any information, and so there's no integration and no consciousness. On the other side, you can have a system that is integrated, as you see here on the right. However, the response will be the same everywhere. It's stereotypical, and so that doesn't allow any consciousness. So if we come back to our illustration, that's how it looks like. So you have incoming information that comes in the brain. It activates this content-specific processor here in green. Here, visual at the back of the brain. If it's auditory stimulation, it's more in the temporal area. And this is segregated, so it doesn't reach consciousness. To reach consciousness, it has to be integrated in what is called the posterior hot zone. And this includes the parietal area, occipital area, and temporal area. And it has a phi measure that measures the complexity of the brain. Phi cannot be tested empirically yet, so we have proxies, and I'll show you one just after. And once we have this activation in this hot zone at the posterior level, then this can give consequences or can give some output. For instance, you can have a motor response or a verbal response. You can also have other content-specific neural correlate of consciousness like working memory and attention. But that's not part of the consciousness per se. So some of you may know that those two theories, they have proponents, and now they have an adversarial collaboration where they work together to test these two theories using the same specific experimental procedure. And so it's ongoing. And basically, the global neuronal workspace says the consciousness is at the front of the brain, and IIT says it's at the back of the brain. And so they have preliminary results showing that both are sometimes right or wrong, depending on what kind of experiment we are performing. Then the third theory that I would like to present is the recurrent processing theory. So this is from Victor Lamé, and it comes more from the visual perception research field. So in this sense, you have, again, incoming visual stimuli that will activate visual brain area, V1, V2, V4, TE. And this will allow to have information about the location or the shape of the visual stimuli, but it's not enough to be conscious. So to start to be considered as conscious, you have to have this localized recurrent processing, as you can see here in orange, and that will allow possibly a conscious percept. But to be fully conscious or fully reportable verbally, and then again, this information needs to be processed more globally into this frontoparietal network that you can see here in red, using this widespread recurrent processing. And here again, you can have motor output afterward, like here in blue. And then the last theory is the predictive processing or predictive coding from Carl Froisten and colleague. And they claim that in the brain you have higher order network, again more into the frontoparietal network, that have canonical predictive coding circuits who give already hypotheses about the world. So we have some already prediction in the brain. And then on the other side, you have again incoming stimuli, vision, somatosensory or auditory stimulation, and those one will activate those lower order network. And from there will be a comparison between the higher order network and the lower order network. And if there is a mismatch between what you are expecting and what you are experiencing, then you will have this feed-forward connection, and that will allow consciousness to appear. If you have any alteration between higher to lower order, it will induce a loss of consciousness. And if you have any alteration between the lower to the higher, you will induce disconnected consciousness like dreamings. So that was briefly 4 theories of consciousness, and here I would like to show one specifically empirical data to show you how you can link the work we do at the clinical level or experimental level and to match it with the theory of consciousness. So this is the work we have been doing with the University of Milan in Italy, the team of Marcello Massimini. So we use transcranial magnetic stimulation combined with electroencephalography. You stimulate the brain and you see how the brain reacts to the stimulation. And we have performed that during general anesthesia using propofol, xenon, and ketamine. And so what we observe is here on the left, it's the propofol stimulation. So the first 3 is when we stimulate the frontal area. The last 3 is when we stimulate the parietal area. In gray, you have the stimulation of the TMS, the electrical responses in gray when you are awake and conscious, and in blue when you are under propofol anesthesia. And what you see here is in any case, when you stimulate, you do have a response of the brain, but this response is very small, you see here, and it's local in a way of after, and it's very quick. So after a certain time, here maybe 100 milliseconds, you don't have any response. So in this case, if we link that to the theory, we see that there's a loss of integration that prevents someone to be conscious here under general anesthesia. On the other side, if you have a xenon anesthesia, you have a different response in black. You have a big slow wave everywhere. But it's the same slow wave, it's the same shape everywhere. So there's a loss of differentiation or information that prevents consciousness to happen. On the contrary, when you have ketamine anesthesia, you see here in red, it's pretty similar than when you are awake and conscious. And so here we can say that the participants were conscious in a way of when we ask them after they recover, they all experience some kind of crazy, sometimes subjective experience during the ketamine. So in this case, you have integration and information. Then we went one step further, and then we developed the perturbational complexity index. So here we look at this brain response and we compress it using an impulsive complexity index, and that gives us a number between 0 and 1. If you have a number below 0.31, you are considered unconscious, and this is the case here in blue when you are in non-REM sleep with no dreams, under midazolam, xenon, and propofol anesthesia. Wherever you stimulate on any participant, you don't reach that threshold. However, when you are dreaming, in REM sleep, or under ketamine anesthesia, when we stimulate the brain, we have a high perturbational complexity index, as you can see here in green, and those numbers parallel the numbers of anyone who's still awake and conscious here in the room with those red dots. And then we went one step further again with the University of Korea, where we developed the explainable consciousness indicator, which can be split in two to measure arousal and awareness. And I will just show you here that if we ask the system or the mathematical approach to tell us which brain region is important for this indicator, you see that every time the parietal area is the one that is the most relevant. So parietal area is more related to consciousness according to this study, so it goes more in line with the information integration theory that we discussed just before. So in conclusion, I hope I show you that theory is important to better understand anesthesia, but also other states of consciousness. And on the other side, it's also important to have empirical data to fine-tune the theory. And so in essence, we want to combine both data-driven approach and theory-driven approach. I thank you very much for your attention.